Hello.
Bismillahirrahmanirrahim. My name is Uzair Ali, and currently I am working as project coordinator at PATA HealthNet Echo Pakistan. We welcome you all on behalf of our organization, especially Professor Fareed Minhas. Welcome, sir, to our forum, and we are highly obliged to have you at our platform. Today, we are going to have 4 series of sessions.
उजैर साहब मेरी आवाज आ रही है?
जी सर,
जी सर, आवाज आ रही है।
Now let's start. Bismillahirrahmanirrahim. First of all, I am very thankful to all of you for joining us, and I'm sorry for the delay. There was some anyhow, I have the honor to introduce Professor Fareed Minhas, and Professor Fareed Minhas is well known, and his contribution to psychiatry and behavioral sciences will always be remembered.
सर सॉरी फॉर इंटरप्टिंग यू प्रोफेसर अफरीद साहब। सर अगर आप अपना माइक थोड़ा नजदीक कर लें।
ओके, अब
Yes.
सही
सही है।
ओके, मैं बता रहा था भाई प्रोफेसर फरीद मिन्हास साहब को इंट्रोडक्शन की जरूरत नहीं है, क्योंकि वो उनके खिदमात साइकियाट्री के लिए, बिहेवियरल साइंसेस के लिए, चाहे वो इंस्टीट्यूट ऑफ साइकियाट्री के प्लेटफॉर्म पे
एक्सक्यूज मी सर, सर फिर आपका माइक दूर है।
और उसके साथ
आवाज क्लियर नहीं है।
अब सही है। अब ज्यादातर मैंने जो बोलना था, फरीद साहब ने बोला है कि बात ये है कि प्रोफेसर फरीद मिन्हास की खिदमात साइकियाट्री के लिए, चाहे टीचिंग के हो, रिसर्च हो, इंस्टीट्यूट ऑफ साइकियाट्री या सीपीसी के लेवल हो, उसको शानदार खिदमात हमेशा ही याद रखा जाएगा। और मुझे एजाज है कि इंट्रोड्यूस करा रहा हूँ, और मैं बहुत से लोग बुला रहा हूँ कि उन्होंने के लिए हमारा और मैं इसके साथ साथ मैं जो ऑर्गेनाइजर है उनको बुला रहा हूँ, जैसे से आपका और सारे लोगों का इससे पहले जी करो मेरे साथ में टाइम उसके लिए माफी चाहता हूँ। और अब मैं चाहूँगा कि प्रेजेंटेशन शुरू करें और हमें मास्क कराएं अपने नॉलेज से। और थैंक यू वेरी मच।
Does everybody can see the presentation I have shared?
Yes.
Yes. Fareed sir?
जी।
Can you see the slide?
Hello.
जी जी।
Sir, can you see the slides?
जी बच्चे, I can see the slide.
Okay. Let's start. What's happening?
Ji sir, should I run the slide? Should I go next?
Is my and am I supposed to start now? मुझे आवाज नहीं आई आपकी साहब जो बोला। I couldn't hear.
Yes sir, आपकी आवाज आ रही है, स्लाइड भी नजर आ रही है।
मेरी आवाज आ रही है आपको?
जी बिल्कुल साफ
जी प्रोफेसर अफरीदी, मैं जरा टेक्निकल पॉइंट ऑफ व्यू से 2-3 चीजें बता दूं। आई थिंक सो जो माइक्रोफोन आप यूज कर रहे हैं ना, वो इन्होंने जूम पे कनेक्ट नहीं उससे किया हुआ। आपका अपने टेक्निकल असिस्टेंट से कहें कि वो सेम है सिस्टम ना करे, आपका जो एक्सटर्नल माइक्रोफोन है उसको क्लिक करे, फिर आपकी आवाज क्लियर आएगी। आप जो बोल रहे थे किसी को कुछ समझ नहीं आ रही थी। और सेकेंडली, आप जिस रूम से ज्वाइन कर रहे हैं वहां पे मेरे ख्याल में 2 लॉगिन्स लगे हुए हैं। अगर 2 लॉगिन्स आप जरूर लगा दें, लेकिन दूसरा जो कंप्यूटर है उसकी आप वॉल्यूम बंद कर दें, वरना वॉइस एको वो शू शू की आवाजें आएंगी। थैंक यू।
Should I start or should I wait?
Yes.
सर आप शुरू कर लें.
Okay. I'm very thankful to Afridi and his team for taking such an excellent initiative as the president of the PPS. I think he has shown a true leadership in the true sense. And starting this email session with the colleagues from the Parsa HealthNet Echo is a wonderful initiative, because nobody in this world can survive alone. It is always a world and time of partnerships in which various partners do different kinds of things and then bring things to an order. And before I start my talk on the borderline personality, I would like to wish you all and your family members a very blessed time. We are passing through the pandemic, and this pandemic has caused lots of havoc and problems for us. And I hope and wish and pray that all of you remain safe and your families remain safe during this crucial time. Now, let me come to the subject that Afridi wanted me to speak today. It's about borderline personality disorder, and it's mainly because of the fact that for last 3 years or so, I had motivated myself to not work in everything, but to work only on 3 things. And I'll tell you later what those 3 things are. But certainly, borderline personality disorder is one of them. Can I have the next slide, please? And the way I have set out my slides, I know that I'm talking to the postgraduate trainees because that's the main theme of this lecture series. So I've not deviated from the requirements of what the postgraduate trainees would need. And you will see that I'll talk about the concept, about epidemiology, classification, etiology, treatment, course and outcome, and future directions in terms of the borderline personality disorder. Next. Now, as we see, next slide, Vijay. These are various ways of describing borderline personality disorder, and we consider them as a psychological equivalent of third-degree patients. These third-degree burn patients, and these are people who have no emotional skin. And I'll illustrate this point further, what do we mean by their emotional skin. And the skin, since it's not there, even the slightest touch or the movement can create an immense suffering. And that's given by the lady who worked very hard on the borderline personality disorder, and that's the quotation that I took from there. Next. The dilemma that we face is that as trainers, we are used to train our postgraduate trainees in the matter of those disorders which come to our clinics too often, which come to our teaching hospitals, and most of the teaching is based on the outpatient setting and less is based on the inpatient setting. And the personality disorders in general, they are inconsistent, variable, and unscientific assessments that we do in a government setting or during the training years. And if you look at your own hospital records, you will very seldom find ICD-10 classification of what borderline personality disorder is, mainly because our professionals lack time, knowledge, and skills that they're needed to follow those models. And most people, even if they refer to these patients, they refer to them as treatment resistant. We have very less number of psychiatrists. We have more number of patients, and to deal with personality disorder is not an easy thing. And very often, as a clinician, you will not like to have a diagnosis of borderline personality disorder because this patient is going to take at least the time of 10 patients. And then very often we don't have time to do all those things. And these patients would come frequently to the hospitals. They would come for treatment. They would choke up your emergency departments, and they would limit your resources, and they would exhaust them badly. Next. And then the carers who look after these patients, they are often very ill-equipped themselves. They don't know how they are going to treat and look after their violence, whether they should be ridiculed or these patients need to be abandoned. Nobody knows about this. And the patient and the families are in dire need of support and understanding, which many mental health professionals simply don't have time or maybe the vision to do all these things. Next slide. Now, if you look at the number of people who have this disorder, about 6% of the world's population would have this disorder. And this would be often stigmatized, difficult to treat and manage. These patients would require personalized management plan. They are pervasive and they're very resistant to change. And there are false views that people accept and expect from them that these people are doing it intentionally, maliciously, and they're trying to manipulate. And as a psychiatrist, we tend to take a very different opinion and a very different view that these people are just spoiling their life and they're doing it purposely and they don't want to get engaged in any form of treatment. Next. Now, this is a very typical slide that says that the definition of borderline personality disorder is that it is a pervasive pattern of instability, which is of interpersonal relationships, self-image, marked impulsivity, which begins by the early adulthood, and it presents in variety of contexts. And you need to have 5 or more of the following that are given below. And the most important one are the imagined fear of being abandoned. Now, why do they think that they're going to be abandoned? That's a very important question that you need to understand. Because they feel abandoned because they are not secure with whosoever brought them or whosoever was the important relationship in their life. And I'll talk about that later. And since they're very insecure, they have a feeling of being abandoned. They just cannot foster and form the relationships. And each relationship has a degree of flexibility, and people with borderline personality disorder are absolutely prone to have a sustained relationship, and their relationship are very intense in each direction. There are variety of identity disturbances of self-image, of body image, and they think they are not as good as they should be. They cannot do as good as they want to be. They are in the wrong role, or the different parts of the body may not be as good as they want. Impulsivity is another character which nothing adds nothing to our value in life if we are impulsive, whether we are doctors or we are students. But impulsivity is a hallmark of the people with borderline personality disorder. And then the next item that you see in the list is a suicidal behavior or the deliberate self-harm. Very often you will see that deliberate self-harm, suicide is such an important area in which we hardly get time to assess whether their personality, they have a typical kind of a personality or not. So suicidal behaviors are predominantly linked to people with depressive illness, and we look into those. But deliberate self-harm and suicide is a very important area in its own right that we need to understand. These people with borderline personality disorder would have the effective instability, and they would be very good to you at some time, and they would be very bad. They would be thinking that they are in control. They will lose control at other times. They can have feelings of emptiness, and the anger fluctuates between mild anger to a severe anger, and they just cannot have the sustained degree of effective stability in their life ever. At times, they would have paranoid ideation, and then dissociative symptoms that are so common in this part of the world that these people would have the dissociative symptoms coming time and again. Next, please. Next slide. Now, this is a slide that I put forward for the better understanding of the whole thing, you need to have the genetic factors in mind. You need to have the adverse childhood experiences that I'll explain to you in a little while. Then that brings us to the biological factors and the psychological factors. And if you put down all what I have said in the beginning about the cluster of symptoms, you will see that the psychopathology of borderline personality disorder either falls in the affective dysregulation or the behavioral dysregulation and disturbed relatedness. So just remember this slide, even if you don't remember anything else from my lecture today, because this is a slide which causes the basic understanding of why people with borderline personality disorder are the way they are at this point in time. Now, I shall explain to you the various details of this slide. These slides would be available, so don't take any effort to write them down, and you can refer to these slides whenever you get time. Can we go to the next slide? Now, actually, of all disorders, we don't know the etiology as such, but then we know that the linkages between biological factors and invalidating childhood environment are at play. Studies have shown that variation in the gene which controls the way brain uses serotonin may be related and may be affected in borderline personality disorder. Next. Now, I have the references for those of you who require them. The biological factors are increasingly accepted in this disorder. The twin studies show the heritability of 0.6 to 0.7%. The first degree relatives are 10 times more likely to have borderline personality disorders. And some of these genes are associated, have been identified by Lübke et al. In 2014. And the imaging studies of borderline personality disorder will show gray matter changes in the prefrontal and the limbic regions, the dysregulation of the corticolimbic circuit, which results in the emotional dysregulation. And that was the work which was done by Rucco in 2013. Next. Now, the other areas which are hot, heated, and take a different and a longer time to cool down are the amygdala, hippocampus, hypothalamo-pituitary adrenal axis, and the prefrontal cortex. They are excited. Maybe the serotonin is acting on them, or their chemical, their psychological wiring is such that they are on the fire all the time. And there is a kind of istirab in these areas that the studies have found out. Next. Now, I think biology alone is very boring. Psychodynamic things make it even more interesting, and I think that's what psychiatry is all about. You can't change amygdala a lot, but you can change the influences of the amygdala, and that's where the interesting things are coming out. The disturbed theories of relationship with the mother at the stage of individuation was the earliest thing. That was Kernberg's point in 1975. The effective bond between caregiver and infant, or the infant whose needs are met, explores her surroundings with the sense that the caregiver is going to look at her, which is a secure base, and when in distress would turn to the caregiver as a kind of a safe haven. Now, what all these things are meaning is that I'm coming to the fact that attachment plays a very important role in the psychodynamic factors of people who suffer from borderline personality disorder. Let me take you a little more further into it. Next slide. Now, okay, I think there's some problem with the slide. That slide about the psychodynamic factors would come back, and we will get back onto that. I'm making a little change here. Okay, thank you for giving it back. Now, I think what I wanted to explain here is the fact that if the child has a good attachment and is aware of the fact of the safe havens and can relate very easily, then the child gets a secure base for the adult life. Whereas people with borderline personality disorder have an impaired attachment with their caregiver, with their parent figure, and because of the attachment problems, all the symptoms that I have explained, that they have a feeling of emptiness, they become very impulsive, they feel a feeling of boredom, their feelings of abandonment, those are all psychologically orientated, and psychodynamic perspective in borderline personality disorder remains very important. Now, just imagine a person who doesn't have a secure attachment, has a poor self image, does not relate to the parent care, and he lives in an environment which becomes very abusive. And that brings me to the next slide. Next one. Next slide, please. Yeah. Now, adverse childhood events are very important in the etiology of all psychiatric disorders. But adverse childhood disorders are even more important in borderline personality disorder. And research over the past decade or so has emphasized the importance of childhood experiences. Look at the bullets that I've put down for you underneath. 87% of people with borderline personality disorder have a childhood trauma of some kind. 40 to 71% have been sexually abused. 25 to 71% are physically abused. And we know that earlier the age of onset of the abuse, the worse is the damage. And that again brings us to the point that attachment, identity, and the ability of making sense of the feelings are increasingly seen as interlinked, and all are adversely affected by the abuse or neglect in the childhood. Now, if you remember my last bullet, I will come back to this bullet again, because what is the treatment of a borderline personality disorder going to be? And this bullet is going to be the hallmark of many of the psychological treatments that you and I think patients with borderline personality disorder are going to benefit from. Next one. Now, these are series of slides that I have borrowed from Dr. Aisha's lectures when she talks about attachment. And these are the attachment styles given by Ainsworth. And my aim today is not to go in dig deeper into the attachment styles at this point, but I think for the reference, this is going to be very important. And we are going to be talking about the attachment in subsequent talks. And I'll tell you how and why. Next slide. Now, Bowlby became very important because of the fact that he worked a lot on the attachment, and his model means that the mental schemas of self and others would serve as the developmental nucleus of identity formation, interpersonal regulation, and interpersonal attitudes. And that is what, boys and girls, you will see in the number of factors or number of clinical symptoms of borderline personality disorder, that the nucleus, the developmental nucleus, has either not developed or has been eroded because of the adverse childhood events that we see there. And Bowlby also said that infants who is nurtured develops working models of others as reliable and supportive. One who is ignored constructs a schemata of other as uncaring. Now, it all depends when this nucleus was developing, what the world looked like to that individual at that point in time. Next. Now, I think I have alluded to the fact that deliberate self-harm and suicide are very important features in borderline personality disorder. And we know that these people are at an elevated risk of self-harm and suicide due to the mixed emotions of intensity and impulsivity. The American Psychiatric Association associates that 8 to 10% of people with borderline personality disorder will die by suicide. And what is important to keep in mind is that deliberate self-harm in the community is in borderline personality is elevated to the range of 60 to 70%, but the number of suicide thankfully remains much lower, which means that the burden of borderline personality disorder is more with deliberate self-harm rather than with suicide. Next slide, please. Now, these are some of the reasons that I have been able to get from people, and I'm sure you will have the examples when you look after these patients, that they will find a very reasonable explanation, which is very painful at times, to justify their acts of deliberate self-harm. And for example, they would say that to feel something, anything, to make others feel better off, how else can I make myself feel better? And one of my patients said, the moment I see the blood oozing out from the cut that I put on my arm is the best satisfaction that I can ever get from. And she thinks that this is the best way. When she bleeds physically, she gets psychologically satisfied. So badly is the damaged developmental nucleus of Bowlby in this young girl that no matter what counseling or what psychotherapeutic techniques I use, she is just inclined and hinged onto this idea that this is what I feel and this is what gives me the maximum burden. So if I go on to describe each one of these patients, it will waste a lot of your time, and I don't intend to waste your time, but I will leave these slides for you to listen as some of the explanation these patients have been giving me over the years. Next slide. Again, the same verbatim from the people that I get. Next slide. Now, some of the examples, I have thousands of these pictures in my telephone, despite that I just picked out 6 of them for you. No place in the body is safe when they come to cutting. And men, women, young, old, there's an endless list of deliberate self-harm that these people do, and we need to keep that thing in mind. Next. Now, I want to change the gear by telling you that why our best institutions don't make a diagnosis of borderline personality disorder, because borderline personality disorder is like the ring of the beautiful ring finger, ring that you wear on your fingers. And in the middle of it is the crown or the big diamond that you wear. The problem is that borderline personality disorder becomes camouflaged with the other list of psychiatric disorders that are given in this slide and the references given down below. People with borderline personality disorder have about 45% of overlap with borderline personality disorder. People who have depressive symptoms and anxiety disorder, around 42% would have that kind of disorder. And then you'll see on this slide, I don't want to go into the details of all these disorders, but the concept of comorbidity is very important. Now, here I'm going to take a tangent and address my postgraduate students in a very different way. You are in an exam situation. You have made the diagnosis of of bipolar mood disorder, but you won't have time to make the diagnosis of borderline personality disorder. But then when you come to talk about prognosis, the prognosis of bipolar mood disorder is very different when it does not have an associated borderline personality disorder or whatever personality disorder is associated. And very often as clinicians, when these two things are combined, we see bipolar disorder or depressive episode getting better, but borderline personality disorder doesn't get better because the treatment is different for both. And when there is a comorbidity, the course becomes longer. And the moment you get a feeling that your primary psychiatric diagnosis is not responding the way it should be responding, please think that the underlying personality, may it be borderline personality or any other personality, that is going to affect the prognosis and the response to the treatment that you will give. So please remember this list of comorbidities that I've put down for your ease at this point. Next. Now, let's change gears and think about what treatment is going to be. Now, as trainees, we all know that biopsychosocial model of treatment is what we need. And I will talk about the same model that I have been teaching for a long number of years. And I will try to give you the bullets so that you can fortify yourself when you want to give the diagnosis of borderline personality disorder. We understand that there is a dysregulation of relationships. We understand that these people are very intense and they fluctuate quite a lot. The major goals of the treatment would therefore depend that we want to build up an emotional regulation muscle for them. We want that their emotional reactivity should be controlled, and we need to give them skills to better respond to the emotional reactions. And we also want them to develop a secure bond with a mental health professional, because that bond is often foundational in the recovery of acceptance and validation. Because these patients who have a very poor bonding and attachment with the caregivers, those caregivers cannot tell them what is wrong with them. And that is why I said to you in the beginning that we need to know what we want to tell the patient, and also what we want to tell the patients and their relatives, because the relatives are going to deal with them. And the therapist comes in as a surrogate parent who tries to establish a different kind of attachment that these patients and these individuals have lacked in their life, and therefore their emotional reactivity comes in. And that's where a psychiatrist or a therapist becomes a punching bag of these patients, because they will throw everything and dump everything. And those of us who are not prepared to listen to these patients will never open up. These patients have a problem in opening up their psychological bond and psychological hurt. And until and unless the psychiatrist has these foundations in his or her mind, nothing is going to work. So remember that National Institute of Mental Health in 2018 identified the major goals of treatment in borderline personalities in these three headings. Next slide, please. Next slide. Now, I looked at the literature, and I found that if you want a comprehensive package, Peter Tyrer is the one who has worked a lot on personality disorders, including borderline personality disorder. And I couldn't find a better review article than Peter Tyrer's 2004, fairly old, 16 years old, but I don't think I've found anything that replaces him. And I think I'll lay the challenge on to the young trainees. If they can find a better review article, they should send it my way also. He concluded that if you look at the psychopathology of all the things that are happening wrong in borderline personality disorder, an equivalent amount of psychotherapy comes forward to deal with it. For example, for reflecting the capacity and the emotional interpersonal relationship, psychodynamic theory and the therapy becomes very important. And if you want to tackle the dysfunctional core beliefs of borderline personality disorder, the cognitive therapy becomes very important. And when you focus to reduce the self-harm to achieve the transcendence of these patients, DBT, or what is known as a dialectical behavior therapy, becomes very important. If you want to focus on the attitude and the behavioral changes, the concept of therapeutic community becomes very important. And if you want to talk about the greater self-understanding, cognitive analytical therapy becomes very important. But you say, no, we want to deal with the maladaptive behaviors, then behavior therapy becomes very important. And if you want to take up the environmental adjustment for minimizing the impact, then the nidotherapy becomes very important. And the details of that you will find in various books that are available here. Next. Now, this is a list that any trainee in mental health or in psychiatry needs to know about these structured therapies that are available. Now, I want to make some confessions here. Psychotherapy is not the most well-taught subject in our postgraduate years. People have no knowledge themselves. The trainers themselves have no knowledge about psychotherapy. Their environments are not such that they will provide the psychotherapeutic training for the individuals. But in last 10, 15 years that I've worked with people in this field, I now know and I can rely with a lot of satisfaction that people are developing psychological methods of treatment relevant to the context, cultural context of Pakistan much more than there were ever before. And therefore, I'll mention some of those as I go down. But then for borderline personality disorder, the cognitive therapy, cognitive behavior therapy, dialectical behavior therapy, individual therapy, group therapy, and mentalization are the therapies that are recommended. Now, you can, if you are a student of Bashir Saab or Mawad Rana Saab, you don't need anything to learn from me because they are the masters in this area. If you want to talk about DBT, there are people, Farooq Naeem and cognitive behavior therapy, who have invested a lot in terms of training materials that are available. But does that reach our postgraduate training is my question to myself and to the Dean, very keenly listening, that how can we improve the teaching and training of psychotherapy for our postgraduate trainees. Now, let's move forward. Next slide, please. Now, you see again here that the role of the therapist in here is that the therapist is going to provide a secure base and is going to use the principles of attachment that were missed out or badly coded by the individuals when they were growing up. And then we have to assist the patients. But I've lost my slides. I've lost my slides. Something wrong? Hello? Alia? Hello? Are we there?
These slides are shared.
बच्चे मेरी स्क्रीन जूम आ गया उस पे खाली.
Is everybody can?
I've been blinded with the.
Sir, can you see it now?
Nah, बच्चे, I can't.
Okay.
Sir, can you click the button join meeting again or back to the meeting on Zoom?
Okay.
Sir,
I've done that.
Can you see the slides now?
Yeah, they came and something went. Yeah, I got them. Thank you. So, इसको मुझे पूरी कर दो. अब आ गई. Okay. So I think, sorry about this interruption. And the treatment implications are that the therapist here is going to be the secure base and the attachment figure. And our role, whichever form of therapy that we take, is going to be in exploring the past and the present attachment relationships and making us understand that how they contribute to the internal working models and her difficulties or the patient's difficulty at that point. And through such explorations, we would need to take patients, revise their internal working models, and develop adaptive views about self and the others. Next. Now, the process of mentalization is little different than DBT or CBT or the nidotherapy that we talk about. This is again based on the attachment theory, and it shows the results are indicating that it has a good effect. But for the treatment to be successful, it is must to have mentalization as its focus, or at a very best, at least stimulate the development of mentalization as an epiphenomena. And it is important to foster the capacity to mentalize and to revert the harmful effect of attachment, insecurity, and personality development. And I'll explain to you what I mean by mentalization. Next. Next slide. Now, mentalization, simply defined, is the process by which we make sense of each other and ourselves implicitly and explicitly in terms of subjective states and mental processes. And we think that loss of mentalization is a core feature of borderline personality disorder. This attaches from the early development, and it focuses on establishing the sense of self and helping patient maintain an optimal level of arousal in context of a well-managed attachment relationship between the patient and therapist. Next. Again, I'm not going to go into the details. You will have the slides and you will see that these underpinning techniques are no different techniques than we use for the stress management or for counseling and psychotherapy that we do in all settings. And to me, if a doctor has the basic idea of psychotherapy and counseling and takes the understanding of understanding the problem and tries to relate those problems with the early adverse childhood events, with the attachment problems, and with the possible other abuses that the patient has suffered, that would engage them into a kind of a generic psychotherapy techniques such as empathy, support, and clarification. And then they can move on to the other interventions which can be specifically designed to treat these disorders. Next. Now, I said we are going to use the biopsychosocial model, and let me say very clearly that if there is a disorder which is only borderline personality disorder, drugs have no role to play in the treatment. But as I have alluded to the fact that borderline personality disorder frequently becomes as a comorbid condition, therefore you will treat the comorbid condition appropriately with the antidepressants or the antipsychotics with whatever the diagnosis is. And these are the bullet points that I want to conclude the section on the borderline personality disorders medication part, which means that psychotropic medication is not curative and does not address the cause of borderline personality disorder. The principal use of medication is to treat comorbid condition, clear-cut, for example, depressive episode, and some of the core symptoms of borderline personality may respond to targeted medication in some patients only, some. And a clinician wants to relieve his patient's suffering in whatever way he can, therefore, first do no harm to the patients. Using these drugs for a clear-cut diagnosis of a borderline personality disorder for a short period of time is limited, is not a crime. But please be aware that you have to treat the patient and tell the family that this is just an adjunct to the psychotherapy that this patient is going to have. Next. Now, last part that I want to talk about is about the prognosis and the outcome. We know that the borderline personality disorder has a long-term, chronic, fluctuant course exacerbated by periods of stress, and that may even surprise the clinicians that the first time presentation of a borderline personality in an old age. It is widely suggested that this is not a single entity, and there's a very influential outcome study by McLean hospital study in which patients were followed for 10 years. 39% of these patients were in remission at 2 years, and further 22% by 4 years, and 88% by 10 years. The high rates of suicide, 8.5%, raising the suspicion of an effective atypical disorder associated with this. So it's a long course that we cannot end. It's a long innings that people play with borderline personality. Next. Now, I think this is a very important editorial that my colleague, Professor Muhammad Rana, Rusham Rana, and Seher Riaz wrote in JPPS in September 2018. And borderline personality disorder, it's here to stay. And I am so thankful to these people that they picked up this important area, and they highlighted in the editorial of the JPPS. And I think if you read that editorial, that explains many of the things that we've been doing over the years and the rationale behind it. Next slide. Now, ever since I retired, I focused my energy on three things, and I formed the interest groups. And one of the interest groups is on borderline personality interest groups. And many of my colleagues in the audience today are members of that interest groups. And what are the aims that we have formed this group? That we want to bring out a manual which includes the consensus guidelines for the assessment, evaluation, diagnosis, and structured management care. We want to have the information care resource for medical professions and general community. We want to have the support group for the patient and families. We want to provide training guidelines and forming training of the therapists. We want peer supervision for colleagues, combining the confluence of experienced and younger colleagues. And we want to establish a kind of a workshop or a certified course for the borderline personality disorder. Next. This is the borderline personality interest group where we decided that we're going to write a book, and the chapters are given down below. And I'm so grateful to my colleagues in this slide. Aisha Minhas, who is sitting with me, looks after a major part of the attachment and early figures. David Mumford, our colleague of Pakistan, our colleague from United Kingdom and a friend of Pakistan for a long period of time, has worked with us. Muhammad Rana has been a tremendous support. He is supporting us a lot. Mudassira, Masood, and Naila Mir are the people who are running the borderline personality interest support group. And then Rusham, with her genetic genes of counseling and psychotherapy, has joined our party. Sadia Muzaffar, a colleague from United Kingdom, has been a regular person that she has been working with us. Seher Riaz, Savera Mansoor, Sundar Swatma, Yusuf Raza have all agreed to write this book. But there are two important other finds: Imran Khan from Peshawar and Bashir Ahmed from Peshawar again. They are the ones who are the support for running the borderline personality interest group. And I have a confession to make that when I was preparing these slides for the lecture, I have used the material that my colleagues have prepared, and on their behalf, I have used this material because this is a common property. But I think I must acknowledge that some of the slides have been taken up by the lectures that each one of these individuals had shared during the borderline personality group. Last slide, please. That's a slide which makes me thank Iqbal Afridi once again, and thank all of you who took trouble on an impending weekend to join me from 1 to 2 p.m. And my email is given below. Either you will give the feedback to the boss, or you can give me an individual feedback. It's been a great pleasure talking to you, and I'm very happy to answer any amount of questions that you may have. Thank you. Back to Iqbal.
Thank you very much, sir. The mic is over to Professor Iqbal sahab.
First of all, sir, I'm very thankful to you for spending time, and the comprehensive talk was very useful for everyone.
प्रोफेसर इकबाल साहब आपके साथ सेम इशू आ रहा है, आपका माइक आवाज नहीं आ रही.
अच्छा, अब आवाज आ रही है
जी? एक्सीलेंट, प्लीज सर.
अच्छा, sir, Professor Farid Minhas, I am very thankful to you for sparing time and for this comprehensive talk. And really, we learned a lot, and also we realized that we have to do a lot of things for this domain of borderline personality disorder, because हमें अभी ये भी नहीं पता कि मरीज के घर वालों को क्या कहें कि इसको बॉर्डरलाइन पर्सनैलिटी डिसऑर्डर है. तो हमें लोकल टर्मिनोलॉजी, और आपने इतना काम किया है, और हम पाकिस्तान साइकेट्रिक सोसाइटी के प्लेटफॉर्म पे वैसे भी चाह रहे हैं कि ये ग्रुप्स बने, इंटरेस्ट ग्रुप, जिसमें हम जो है एक फॉरेंसिक का ग्रुप, एक चाइल्ड साइकेट्री का, इस तरह से ये पर्सनैलिटी डिसऑर्डर वाला स्किज़ोफ्रेनिया ग्रुप, और डेवलपमेंटल डिसऑर्डर, खासतौर पर जो नेग्लेक्टेड एरिया हैं, जैसे हमारे यहाँ मेंटल ट्रेडिशन वाले या ये बॉर्डरलाइन पर्सनैलिटी डिसऑर्डर वालों को जिस अंदाज से तकलीफ उठानी पड़ती है. मैं समझता हूँ कि आज की टॉक के बाद हमें एक नई सोच ये डेवलप हो गई है कि हमने बहुत कुछ करना है, बहुत कुछ सीखना है इस एरिया में. और मैं आप सबका, खासतौर पर हमारे पोस्ट ग्रेजुएट और जिन्होंने ज्वाइन किया है, और साथ साथ जो है ये एको में जो है ना, इसके अफराद जिन्होंने हमें ये सहूलत दी है, ओवैस साहब और दीगर जो है हजरात, उनका शुक्रगुजार हूँ. और नेक्स्ट हमारा टॉपिक होगा, वो होगा चाइल्ड साइकेट्री इन रिलेशन टू कोविड, और वो वकार अजीम साहब कहेंगे. तो मैं आप सबका तहे दिल से शुक्रगुजार हूँ, और उम्मीद है कि ये जो है सिलसिला जारी रहेगा. और आज हमें अंदाज़ा हुआ कि हमें जो बॉर्डरलाइन पर्सनैलिटी डिसऑर्डर्स के लिए जो इंटरवेंशन है, वो सारी ही हमें अपने लोकल कॉन्टेक्स्ट में, इंडिजिनस वे में, सोशली कल्चरली एडेप्ट करने पड़ेंगे. तो आप सबका बहुत शुक्रिया. और अब मैं आखिर में इस दुआ के साथ कि हम सबको
क्वेश्चन आंसर्स, सर देयर आर सम क्वेश्चन एंड आंसर्स, अगर 2-3 क्वेश्चंस आप कर लें फिर उसके बाद.
अच्छा, एक दुआ कर लेते हैं. जी जी, क्वेश्चंस क्या क्या हैं जरा बताएंगे.
सर ये ग्रुप्स में क्वेश्चंस आ रहे हैं, जरा थोड़ा सा ग्रुप चैट देख लें, उसमें से 2-3 क्वेश्चंस आप सिलेक्ट करके तो सर से पूछ लें, फिर उसके बाद इस सेशन को एंड कर लें.
Okay. Do I? This is a question from Aram, and in conjoint therapy, my experience taking the significant others of the family into therapy once trusted must have been established. I totally agree that the family becomes very important in terms of dealing with the borderline personality disorder. And let me share a very common finding that happened. When I tell people that they have borderline personality disorder, they simply don't like this conversation at all. And many of them have refused to continue with the treatment as soon as I give borderline personality disorder. And I realized that the stigma within the psychiatric patient of this diagnosis is such a big stigma that they just cannot tolerate it anymore. And I think the reason that we think that other members are going to be involved and we need to talk to the families about it is mainly because of the fact that we would want a very simple guidelines to be written down for them about this disorder and which are relevant to our cultural norms and values. So the work is in progress. I realize the difficulty, but I don't have the answer at this point because our group is trying to find out the best way of doing this. Then there is another question, should we give the informational care to borderline patients? Is it ethical for them to know their diagnosis? Very good question. I think not giving a diagnosis is equally unethical. Giving a diagnosis is not unethical. It is the acceptance of the diagnosis which is very important. And if I have a cancer and you don't give me the diagnosis of my cancer, this is going to be very unethical. But if you give me the diagnosis, the giving of the detail is ethical, but the volumes of reaction and the breakdown psychologically that it will cause in me is going to be your responsibility to deal with. So you can only tell the diagnosis when you are prepared to deal with the consequences of telling the diagnosis. So therefore, my answer is this, no, this is very, very ethical to talk about the diagnosis, but you should have the knowledge and expertise and the ways to communicate that diagnosis until that time, don't talk about this diagnosis. Sundas wants an answer that what do you do when the patient with this disorder lies manipulated and the family is so fed up by their behavior, they simply don't want to listen to our reasons. Sundas, the problem is that many of these patients don't want to listen to us. We have to make ways of telling them what we want to. And then you go on to say that you've seen two patients who had made a story about abuse, although I couldn't find any evidence in detailed history and collateral accounts. Now, I think that's a very important area, and maybe Iqbal Afridi would like that we should do about the how the abuse presents in our society and how the story of abuse have to be understood, analyzed, and given back. You see, one of the problems is that we think that these people are manipulative and these people are trying to tell us false stories. That's the notion that many of us begin to see borderline personality disorder. And I think that is very important that even if we don't find any evidence and the person is saying that it has happened, I think I personally would believe my patient rather than finding a way that it has not been corroborated by the views. Now, the last question that Sundas, she always asks me difficult questions, is about the transference, negative transference, how to deal with that. I think I'm less worried about the negative transference. I am more worried about the positive transference. Negative transference is very easy, that the patient will stop coming to see you if you don't see the patient in the nice way. But positive transference is going to cause a lot of problems. And that is why you will see that these patients present to the casualty, and sooner or later, they hook the best smart young doctor in the casualty department and get married to him. That's where the transference was dangerous. If the patient doesn't come to you, the negative transference is going to be fine. He will go to another doctor. You will lose the patient only. But if it is a positive transference, you're getting a patient as a partner for the rest of your life, which might be a bigger problem. So think about it, which you want me to speak about more, and I shall give you more answers. Okay. There's another question. That's a very good question that I'm asking, the limitations to avoid transference. I think very good question again. Transference is something so common and so important for doing a good psychotherapeutic work, but the limitations have to come in. And all of us are human beings, and therefore, a doctor can also make mistakes in transference. So is the patient going to make a mistake in transference. And you never, Bashir can tell you more and lecture you for hours and hours on this phenomena. But the most important thing to monitor these transference phenomena in psychotherapeutic setting is to have a supervisor. Supervisor would tell you what you are doing is right or wrong or which way you have to go. So therefore, psychotherapy alone is the most dangerous weapon that mental health professionals can have, because transference is going to come, and if the transference is not there, the psychotherapy will not work. It is the crossing of those boundaries which is dangerous, and we need to take precautions about this. Now, Iqbal, the questions are absolutely fascinating and interesting, and I can go on and on. But I can understand that Dean is a busy man, and you have important things coming up on your agenda. I am a free man. I can talk quite a lot. The only thing which will delay is my departure to Murray. That I can delay. That's not a problem. So how long do you want me to continue?
Professor Afridi, you are muted, please.
भी बेहतरीन है और आपके जवाब भी बड़े जबरदस्त हैं, तो 2 क्वेश्चन और ले लेते हैं.
Okay, okay. What's the question from Imran coming up? Well, if Sundas asks me a question, why would Imran not ask me a question? Sir, what's the rationale for psychotropic use in the reduction of suicide risk in patients with borderline personality? Imran, as I mentioned earlier, that if the patient with borderline personality disorder has severe depression, then that depression needs to be treated regardless of the diagnosis of borderline personality disorder. The patient may need antidepressant, or the patient may need ECT. Borderline personality will not take a driving seat in terms of the treatment at that point. So treat the disorder, and if the suicide is coming because of depression, then you should treat depression the normal way. The role of counseling will come in, obviously, once the suicide is taken care of and you are trying to deal with the borderline personality issues. That's where the question would be arisen. Another question that I think is very interesting, if it doesn't move, is the self-harm in borderline personality only about patient, or it can be the person doing self-harm feels sadistic pleasure in seeing his family members in distress due to him? Good question, good question. And I think if you understand the psychodynamic theories and the explanations that I offered, you will find that these people are not trying to manipulate, or they are not trying to put others in pain deliberately. This is happening unconsciously because people who are important for them now were not playing their important role when the secure attachment bonding was taking place. And therefore, those important figures had neglected the child at that point, and now the child is reacting on those people because they are the ones who are the authors of this disorder. So I would, as a psychiatrist, not take up as a manipulative behavior or as a sadistic behavior of these patients. I would tend that they are miserable people who find no other way to communicate but to use a sadistic method. Okay. Afridi said 2 questions. Okay. I think this is a good question from Malika. here that how long do you think it's going to take for unfortunate fact to change that people in our part of the world see the diagnosis as a way forward for the treatment rather than being offended by it? I think it is anybody's guess. Psychiatry has achieved some degree of respectability, and I'm sure borderline personality disorder will receive some degree of acceptability after we have started to have seminars and talks like this, and people who are the frontline workers, the mental health professionals, the future psychiatrists, psychologists, and social workers, they start understanding the concept of borderline personality disorder, things will change, inshallah. Afridi, back to you.
Sir, thank you very much for sparing time and in a pleasant way you have discussed this difficult domain of psychiatry, that is borderline. It's not only difficult to understand it but also to treat it. With this we will end, but before that हम एक दुआ करते हैं, हमारे इसका रवायत बनाई है कि दुआ करे कि हम सबको और हमारे मुल्क को, पूरी दुनिया को, ग्लोब को जो है इस पैंडेमिक के साथ साथ दीगर अमराज से तहफ़्फ़ुज़ दे और सेहतमंद और खुशहाल रखे। और हमारा अभी ये है कि हमने एक नया सोच ली कि जितने सवालात हैं इनको हम जमा करेंगे और कोशिश करेंगे कि इनको एड्रेस करें। और पोस्ट ग्रेजुएट की जो हमारे तकरीबन मेरे वार्ड से तकरीबन 20 लोग अब इसमें हिस्सा ले रहे हैं, जबकि वहाँ पे हमारा एक नजर आ रहा है अलिया खान के नाम से। तो इसका मतलब ये तकरीबन 200-300 लोग ये देख रहे हैं प्रोग्राम, तो हम इनके सवालात जमा करेंगे और कोशिश यही होगी कि जिसने प्रेजेंटर ने ये टॉपिक था उसको ये रिक्वेस्ट की जाए कि उनको जो है वो सवाल के जवाब रिटन में हमें दे दें, तो बहुत खुशी होगी इसके साथ। आपका बहुत शुक्रिया सर, और इंशाल्लाह फिर आपको हम ज़हमत देंगे। उम्मीद है कि लोगों ने इस डिफिकल्ट जो टॉपिक था उसको अच्छी तरह कंप्रीहेंड कर लिया होगा, और जो कि पूरा समंदर था उसको आपने कूजे में बंद कर दिया, उसके लिए बहुत शुक्रिया सर। थैंक यू वेरी मच सर।
बहुत बहुत मेहरबानी, अल्लाह आपको कामयाब करे। एंड आई एम वेरी इम्प्रेस्ड एंड वेरी ऑनर्ड बाय द वर्क दैट यू आर डूइंग, एंड आई प्रे फॉर योर लाइफ एंड फॉर योर हेल्थ एंड हैप्पीनेस। आप दुआ करा दें ताकि हम इसको कंक्लूड कर लें।
अच्छा सर, एक और चीज़ है कि हमने अब सोचा है कि ये जो इस टेली साइकेट्री के थ्रू जो है हम डिजिटल आपको वो प्रेजेंट करना चाहते हैं, सर्टिफिकेट ऑफ अप्रिसिएशन को, के आप हम तो चाह रहे थे कि उस पर बहुत कुछ किया जाए, लेकिन हमने एक रवायत बनाई है और वो सर्टिफिकेट आपको पेश किया जाएगा और उसके लिए तालियां बजानी है सब ने भाई थोड़ा सा ये सर्टिफिकेट पेश कर दें। हाँ, उसको बड़ा ठीक है ना सर।
Very kind of you, very kind. I am honored to have this electronic certificate, and I think we are learning new ways of dealing with this pandemic, and I can see you wearing masks and everything and taking all the precautions, but my social distancing rules have been violated here because Aisha was sitting next to me, so we are without masks and close to no social distancing at all. So thank you very much for joining in.
I'm also thankful to Dr. Aisha Minhas for sparing time, and she's always supporting the teaching and academic activities. और हम ये कहते हैं कि सोशल कनेक्टेडनेस होनी चाहिए, फिजिकल डिस्टेंस होनी चाहिए, यानी समाजी समाजी और जिस्मानी दूरी को हम फरोग देते हैं। शुक्रिया आपका।
Okay, okay. आप सबको अल्लाह अपना हिफ्ज़ ईमान में रखे।
Thank you very much for attending this session. We will upload the video of this session by the mid of next week, inshallah ta'ala. और जो post session quiz है, that I will send all of you in the evening. So we are very grateful to Professor Farid Minhas, Professor अफरीदी साहब एंड रेस्ट ऑफ द पार्टिसिपेंट्स के आप लोगों ने हमारा सेशन अटेंड किया. थैंक यू वेरी मच. So प्रोफेसर अफरीदी, should I call off the meeting, sir?
तो ज़ेर साहब आपसे ये दरख्वास्त है कि जो सवालात थे बड़े कीमती थे, ये अगर हमें मिल जाए किसी तरह से, आप वीडियो तो आप कर ही देंगे, लेकिन सवालात को भी हम रखना चाहते हैं.
आपकी आवाज मुझे क्लियर नहीं आ रही. मुझे ये समझ आ रही है आप सवालात मांगना चाह रहे हैं सारे.
जी हाँ, जी हाँ, जी हाँ.
अच्छा ठीक है, मैं वो चैट मैंने सेव कर ली है, तो वो मैं उनमें से सवालात अलहदा करके ना आपको वर्ड की फाइल पे सेंड कर दूँ.
मुझे भी भेज दीजिएगा, आंसर दो.
जी सर ठीक है, मैं
बहुत शुक्रिया.
ओके सर, थैंक यू अल्लाह हाफिज. मैं